Hi, I'm Dr. Karl Stonecipher, and we're in this amazing home in Miami, Florida, and we're doing My Next Ophthalmologist Needs No Introduction. So let's see who it is, okay? I'm pretty excited about this. Oh my gosh, it's Bill Trattler.
Yes,
hey, come on in, come on in.
So
welcome.
Wow, what a beautiful place.
Isn't it a great place we got? Hang on. Let's go over to the bar.
Oh, I love bars.
I know. You know, I hear you had a bar.
My roommates, when I was doing my residency, owned a bar called Labrador's Pub in Philadelphia. So I feel at home in a bar.
So, what's your best drink? Can you make me a drink?
Well, I was actually the social director of the bar, so I was never a bartender. But I've learned a couple things in my career, so I'll try to whip you up something that you like. Let's see what options we have here.
Okay, so while we're doing that, you work here in Miami, and where do you work?
So I work at the Center for Excellence in Eye Care, and just so you know, I have a pre-mixed drink that I will put over ice and really.
You're not gonna do cocktails and dreams or anything like that.
Well, we've done that before, but you know what happens is that if I just mix it up like this, it tastes way better.
Awesome. So you work with all these amazing ophthalmologists. Are you like the best ophthalmologist there?
Of course.
Okay.
No, come on. No, we have an incredible team.
So I know you work with your dad. Talk to me a little bit about that.
Oh my gosh. I feel very lucky to work with my father.
Thanks, sir. Oh, grab a beer. You got a beer? Good.
I pulled my beer out, yes. You know. Okay, cheers.
Cheers. Thanks for being here.
Of course. So I'm so lucky I get to work with my dad. So I've been working with him. He's had a fantastic career, so his patients love him. We get to work together in the operating room, seeing patients together. It's been a great experience.
And you work with this lady that's maybe a better ophthalmologist than you, named Jen, I think.
Yeah, well, she is a better ophthalmologist than me. I learn from her all the time.
Yes.
Jennifer Lowe, and I'm very lucky to be married to her. And she's just an incredible physician, doctor, surgeon, and I learn from her every time I get to spend time with her. So, like in clinic, obviously spend time with her outside of clinic, but.
Okay, and so I got one last question for you. I hear you have 3 rings. I mean, I got one in the NHL, but I hear you have 3 rings. Tell me a little bit about being the team doc for the Miami Heat.
I'm very fortunate that my dad was picked to be the team ophthalmologist for the Miami Heat when they first started a little bit over 30 years ago. And then I got pulled in about 10 or 11 years ago as a co-team ophthalmologist with my dad. And the Heat has had some great seasons. So we've won 3 rings, 3 championships. We were very close this year, didn't quite pull it off, but we have just a great team, the Heat are just a great organization, so I feel very lucky I get to help and work with them.
So do you like wear those out to dinner, or you wear that to birthday parties, or what?
Well, I keep mine in a very special place because I did get one, but my father wears his a lot. It's a great conversation piece, and we feel very fortunate that we have those rings.
Do you mind if I pick your brain a little bit more on the chairs over here?
I would love to.
Okay, cool. I want to talk a little bit about your brilliance in ophthalmology, but first I want you to tell me a little bit about your practice. So what kind of lenses are you using? What do you do? What's your practice?
Well, I love cataract surgery and also refractive lens exchanges, and I think those patients are a little bit different, but still at the end of the day, we're using the same type of lenses. And we use a mix of high definition monofocal lenses, obviously high definition toric lenses, and then finally, of course, range of vision lenses. So there's a couple great options there too. So everything from, we're using the Vivity, the Synergy, and Panoptics for the range of vision lenses. We're using both the Invista and Tecnis toric lenses. And for monofocals, we're using the Tecnis monofocal, the Invista monofocal, and the BVI monofocal. Those are the kind of the main ones we're using in our practice.
Okay, so that's a lot of lenses.
Yes.
So I know you're doing like 30 some odd cases tomorrow. Kind of break it down. What's tomorrow look like?
Well, tomorrow looks like, I forgot to mention that one of my favorite lenses is the light adjustable lens. So I'm usually doing between 1 and 3 a week, and those are for my patients that have keratoconus, previous RK, previous LASIK, or patients that just really want to nail monovision. So that's been really helpful for that small group, but it's a lot of work.
Right.
And then it's going to be usually about 30% range of vision lenses, another 20 to 30% of toric lenses, and the rest will be monofocal lenses.
You know, a lot of ophthalmologists today aren't really using the premium channel lenses, whether that's a trifocal lens like a Panoptics or a Synergy, or some of them are dabbling in a Vivity or something. But let's just go to the plain lenses that you're using. So somebody walks in, I've had laser vision correction, I'm monovision, I'm a happy monovision patient. What are you going to offer me? And I want to spend any extra money. I don't have any extra money to spend.
Right. Those are actually not too uncommon patients. And so what we talk about is we really want to nail the distance eye,
of course,
get a really crisp distance vision, and then we got to figure out where to end up with the reading eye. And then, actually nowadays what I'm doing is sometimes I'll mix and match the type of monofocal lenses where I'm going to do a high definition lens in the distance eye to really nail distance, but then also give a lens that maybe is a little more forgiving, that has a little bit more range of vision. Right now, my armamentarium has been mostly the Invista and the BVI lens for that monovision eye.
But what if I've got a diopter more of cylinder? What kind of lenses are you going to use in terms of toricity?
Right, so the same group. So I'm using typically the Technis or the Invista, depending on various aspects. If we're doing more distance or more near, the Invista has a little more range of vision because it's neutrally spheric. So that lens I expect to get a little bit more range of vision. So that's going to be my monovision eye. And then for the distance eye, again, the Technis has is that high definition for distance.
So let's talk about depth of focus for a second. I mean, you operated on my first eye. I'm happy. I'm like, Bill, dude, I can see. So far I can see this beautiful ocean out here, and I'm kind of confused though now because, I'm not sure where I want to be. Do I make my other eye the same? Now remember, I told you I was monovision after laser vision correction. Am I going to use one of these lenses that are what we call a monofocal plus or an extended range of vision, as you said earlier? So for my second eye, are you going to ask me, I don't know, what do I do for hobbies, habits? How do you play that out?
Of course. So, I try to get a sense of whether they spend more time on the computer or more time looking at really small things. Some people may be like looking at very tiny things. Maybe they're going to cut jewelry or do other things that are very tiny. So we want to be a little bit more towards near. Other people are more towards their cell phones and more towards computers. So we're going to cheat a little bit more towards intermediate with some near. And we try to do our best to guesstimate.
Okay.
We'll be happy, but it's always difficult. So having a lens that gives just a little bit more range is always our goal and hope.
So you're a pretty smart guy, I know that. Do you talk about defocus curves with the patient? Do you go through that, or do you just really teach the residents about defocus curves?
I love looking at defocus curves for myself. I feel like I learned and understand how the lens works, and I try to use what I've learned to educate the patient. So I don't quite go over it with them, but I try to educate them. We have residents we work with, and we try to go over that as well. But I think that patients, it may be a little difficult to understand. So
right.
I just try to give them a sense that we're going to do everything we can to make them happy. But obviously there's limitations with the lenses.
And surely you find patients that say, Doctor, you're the guy. That's why I came to you. Yes. So why don't you pick a lens for me? How do you have that conversation? So let's say we're talking about plain Jane lenses. I've already told you I don't want to spend a huge amount of money, but I've got a lot of astigmatism. How do you talk to me or work that in the conversation? And maybe the femtosecond laser in your practice.
I love femto. We do about 70% of our cases do have femto involved, but I'm not the biggest fan of arched incisions, especially after previous LASIK. So I'm using the toric lens, and I think the toric lenses are very affordable, and they work really, really well. And again, we have two types of toric lenses available that are monofocal torics. We have lenses that are meant to be more distance focused or high definition, and some that give a little bit more range. And so we have, again, I'm using more the Invista for my range of vision. I know obviously J&J has their lens as well. I haven't used it as much. I don't have as much experience with that, but I know that they've worked hard to give another lens that gives range of vision.
Yeah. Well, one of the things I want to bring up, I've been working with Graham Barrett for quite some time. I am like you. I use a wide variety of lenses, but my kind of four go-to lenses are a trifocal, and I pick up Panoptics or Synergy, which we're really not talking about right now. I do use the Vivity lens a bit, but if I'm looking at a toric lens, I'm kind of the Technis, eye-enhanced toric guy. Okay. I feel really comfortable with that. I think the centration and the rotation stability is pretty good. And then I'm using this new Rayner lens. I know you and I've talked about this before. You haven't used the Rayner lens, but talk to me a little bit about, negative versus positive spherical aberration. I'm saying if you're talking to a doctor, you're trying to say to a doctor, I'm trying to choose between one or two lenses. How do you pick that?
Absolutely. Well, obviously I've heard a lot about the Rayner lens, and at our surgery center it takes a little process to get new lenses to be approved. So I'm looking forward to getting a chance to use that for my patients. But in the meantime, what I'm thinking about and what we're asking about is that we have some lenses that have negative spherical aberration correction, and those are the ones that are really high def, but low range.
Right.
And if they're more neutrally spheric or positive spherical aberration, they actually end up giving a little bit more range of vision. The definition for distance may not be quite as crisp and sharp as the as the negative aspheric, but they give more range.
Right. Diagnostically wise, so you're teaching me, I'm a new resident, are you using the OPD3, are you using a Pentacam, are you using a Galilei? I mean, I know you got an IOL Master 700 maybe, other platforms, biometry. How are you choosing spherical aberration, neutral, or positive or negative spherical aberration lenses?
A great question. We do have the Pentacam, which I love preoperatively, works really nicely for our patients. It gives a really nice information on the shape of the cornea. And we know that patients that have a normal shape, they have normal shape, but if they've had previous hyperopic LASIK, they have a very steep central cornea, or if they have keratoconus, they have a steep central cornea, so they have negative asphericity of their cornea.
Right.
And so there, we don't want to add with a negative aspheric lens, we want to use more something that is positive or neutral. So that's why I'm using the Invista or some type of positive aspheric lens. On the flip side, a patient that had myopic LASIK, they have a flatter cornea, so that's positive asphericity of the cornea. Again, that's where we want to use a negative aspheric IOL to counteract that to give higher definition vision.
Yeah, so the Rayner lens is not approved in a toric, but I really like it, let's say in those 0.75 diopter or less, but I don't want to pigeonhole it there because other people use laser-made astigmatic incisions or some type of limbal relaxing incision or something. But let's talk a little bit about, I mean, does ABI value mean anything to you? Because I know that the Rayner lens is a 56 and the Technis is a 55 and Alcon's a little lower than that, so I don't want to denigrate any platform or any technology. I'm like you, I'm looking at post-op day one visions and I'm impressed with what these lenses are giving me. So with the Rayner lens, I'm getting like 2016s and 2012s. Obviously, I do eyes a week apart. I don't know where you are in terms of that. In the great state of North Carolina, we can't do both eyes on the same day unless maybe it's a refractive lensectomy. But so do the glistening free or do the quality of the lenses make a difference to you?
Well, I think they do. I mean, I think our goal is to give the very best high definition vision. I love, the outcomes you're describing. Our goal again is to make our patients super happy and as happy as early as possible. Patients realize if they're not seeing well the first day and the first week, because their friends have all had great vision. Their friends may not have seen well for a month, but they only remember that they saw great the next day, no matter what.
Right.
They always say, "Oh my God, all my friends." So
my patient drove home.
Exactly. So, I mean, what you're describing is our goal is to get great vision, high definition vision.
So how do you work post-op day one visions in your practice? So tomorrow you're going to do 30 cases. How are you going to make those patients, happy in terms of feng shui? And I'll tell you my secrets too.
Well, I mean, I think number one is we try to minimize corneal swelling, corneal edema. So
of course,
everything from viscoelastics to minimizing phaco energy, everything we can to make the cornea as pristine as possible, using viscoelastic on the cornea at the end of the case. And I see my patients, just an hour or two after surgery.
Right.
So I really don't get day one. I get a few hours later. So at that point, their pupils are dilated, and they're maybe not, seeing fantastic then, but I'm just working to get them seeing great by the next day.
But, I think the biggest thing about that, COVID came around. You had a person coming in, you still had to have a sponsor, so to speak, and so they didn't have to come back that second day, that day after surgery now. So we've kind of incorporated that both in terms of LASIK. We're now doing more telemedicine for that 1 week and that 1 month. We're doing a lot of telemedicine for cataract surgery as well. We're having our same day post-op evaluation. Now, of course, if the patient has a problem, they're welcome to come into the clinic the next day and either see me or one of my colleagues. I'm there on the day after I operate. But do you think that's made the patients happier being able to see them on that post-op day of evaluation?
1,000%. So think about this. They can't drive, so they have to have someone drive for them. So they have their family member there. They get everything done in one day. They don't have to drive again the next day, especially on patients that drive more than 15 or 20 minutes. At our center, they have to park. I mean, that's always an issue. So same day. And plus, the most important thing is we're identifying high elevated eye pressure the first day. And it happens about 10 to 15% of our patients will be surprised. Someone will have pressure in their 30s, even 40s, 2 hours after surgery. We can identify and treat it and avoid that evening of severe pain and nausea that they could get if they had an elevated, untreated pressure.
Let's switch gears for just a second. Now it's post-op, okay? And we've talked about there's newer types of lenses on the market in terms of the materials that they're made with. So YAG laser capsulotomy rates. Does a hydrophilic lens or a hydrophobic lens, or all these different type of lenses that we have available to us. You know, the Rayner lens, the YAG laser capsulotomy rate is like 1.8%. Okay, my, you know, PanOptics, my Synergies, I think the YAG rate's a little higher than my, you know, basic lens platform or my monofocal plus platform. So are you finding the same thing with the YAG laser rates, or where are you at?
Our goal is to avoid YAG lasers. We want our patients to see great and not end up with PCO. So minimizing that is really important. And I think the lenses do have a role in that. And any lens that can produce a lower YAG rate, I think, is the best thing for our patients. Patients don't want to end up 6 months later with blurry vision. They don't know why, and they're confused. Wait, there's a surgery wearing off. So having a lens that has properties that reduce the need for YAG capsulotomy is really important.
What would you think is your overall YAG laser capsulotomy rate now for a basic lens? I was taught in residency it was like 20%. We're 1 in 5 got a YAG laser.
Right. Well, I think we had a year that I think that overall the first year it seems to be pretty low. I think less than 10% for the typical lenses that I'm seeing.
Right.
I agree that the multifocal or trifocal lenses have a little higher rate in some respects, but I'm also a little bit more hesitant because I know once I do a YAG, I can't switch them out. So I kind of wait till the patients are really, really happy with those range of vision lenses. And for the monofocals, many times they're doing quite well. And I think that thankfully my YAG rate seems to be relatively low. The other group is the light adjustable lens. We want to, again, while on one hand you want to do the YAG, if they were to get exposure to light and need an exchange, you don't want to, again, need to do YAG early. So everything we can do to lower YAG rates is important.
One of the other pluses I want to say, because I'm trying to kind of coerce you to try the Rayner lens a little bit.
Yes.
That they have this new platform. It's available on the computer to look at outcomes. And I think that you and I have friends that look at outcomes, and we have friends that don't look at outcomes. And I think that for me, looking at what my A constants are and maybe intraoperative aberrometry or, you know, some type of centration intraoperatively, do you think you look at outcomes or no?
Well, I love looking at outcomes. I often have some medical students do projects. We looked at our toric.
Cool.
We looked at our toric outcomes. We saw the difference from, like, we were using the Technis platform, and the success rate before they frosted the haptics was actually surprisingly not as good as I hoped.
Yeah.
But then once we did look at the results with the frosted haptics, they were great.
Yeah.
And I saw the difference, and I didn't realize what the difference was until you look at the data. And I think looking at the data is really important.
Yeah. So you're a really smart guy. We've got a few minutes left, maybe. Is there anything you want to add, brilliance in ophthalmology, that you're excited about?
Well, I think, well, first of all, I just want to say about the Rayner lens, I haven't had a chance to use it, but I love the fact that Graham Barrett was behind this lens. I did my research, and he's done so much for us. And, you know, I've been so impressed with, I use his formula, the Barrett formula, for my patients, both, you know, the regular formulas, also for post-LASIK and patients with keratoconus, and it's been surprisingly fantastic for our patients. So I'm really excited because of his involvement in this lens. I'm looking forward to getting some experience with it. So I'm really excited that he spent the time to come up with this new idea, a new concept for lenses for patients that want monovision.
So 5 years down the road, what excites you most about ophthalmology? Give us a pearl.
Oh my gosh. I mean, I think we're in the best field ever. I mean, I think we get to make a difference and impact in our patients every day, from cataract surgery to refractive lens surgery to laser vision correction. And I just feel confident that there's going to be new lens technologies, everything from the AccuFocus is coming out, next generation of all the lenses we're working with now. And we're just going to continue to deliver great outcomes for our patients, and they're just going to make them happier and happier. So I feel like I'm in the best place ever, being an ophthalmologist in this time, and this, you know, being able to help my patients.
And I know you, like me, operate on family, so I've operated on my sister, my brother. I mean, I don't do retinal detachment surgery or anything crazy, but I'm saying if it's in my wheelhouse, cataract surgery or laser vision correction of some sort, how do you pick lenses for your family?
Well, great question. So my mom, I just did her surgery.
Okay.
So she had terrible dry eye, even though she had been on like drops for years.
And you know a little bit about dry eye last time.
I do. Oh my gosh, I was surprised at how bad her dry eye was. We did LipiFlow. I put her on all these different drops. It's still really bad. I couldn't get good readings.
Right.
My thought had been like a Vivity or PanOptics, and she just was not a good candidate. Her macula was great, but just I couldn't guarantee a good case. So we did go with a light adjustable lens.
Okay.
And I was right because I was one diopter off target.
Wow.
And it wasn't because Graham-Barrett's formula wasn't good. It was because we had bad information going in, but I didn't worry about it because I knew I could adjust it. And now she ended up with, basically 20/20 vision in both eyes. And, again, she ended up more distance, but she doesn't mind putting on reading glasses when she needs it. But it was a great choice for her.
And I got to plug one last thing. There was this little study you and I did with some really brilliant people, Marguerite and Eric and a lot of other people. It's called the Phaco study.
The Phaco study, yes.
Yeah. So I think dry eyes is a really important thing.
Yes.
Yeah. So thank you for having me here in Miami. I got a couple more questions, okay, because we've talked kind of the business end of the model. We may be going somewhere later tonight. Where should we eat in Miami?
Well, Miami has incredible options for food, for entertainment. I think we should go to South Beach. I mean, I think that's the destination that everyone who's visiting Miami loves to go. I mean, we have Brickell, but I think, again, South Beach is the place to go, and we can hit some great spots for dinner, and then, of course, great places after.
Are we going to the Fontainebleau? Are we going to the Delano? Are these still hot places?
They're both hot places, but I still think Fontainebleau is a place that we could end up at. It's just a great spot.
So my son is here with me, and the thing I always remember last with you, it was Frank Sinatra's 100th birthday, and we were hanging out at the Fontainebleau. Cool spot.
Great
today and past.
Yes.
So absolutely gorgeous place. I would hope that you would join me on the balcony for one last cheers.
Cheers.
Thanks for being here, buddy.
Thank you for having me.
You are an ophthalmologist that needs no introduction.
There you go. Thank you so much for having me.
All right. Tell Jen I said hey.
You got it. Thank you.
I hope this edition of my ophthalmologist needs no introduction was entertaining, but I also hope it was educational. So we really talked about, the different lenses we're using. We talked about how they're helping us out. And, last but not least, it was in a fun environment. So thanks for being here.
This has been a great experience. I love talking to Karl. We are so excited we get to help patients see better with cataract surgery. And we're lucky to have so many amazing intraocular lenses for our patients. I know I'm excited to try the Rayner lens and looking forward to lots of great experiences in the future.
Cheers, buddy.
Oh, cheers.
Let's go outside.
Absolutely.
Thanks for being here.
Oh, it's great to be here. Thank you for having me.
You here, buddy.
Yes, thank you so much. What a beautiful day.
What a beautiful view.
Yes.
I can't believe you live here every day.
I know, it's a tough life.